25 with a unit on palliative care at the end of life. A unit on palliative care at the end of life. Palliative care originated as end-of-life care in the 1960s. Initially focused on providing relief of symptoms and emotional support to the patient, family, and significant other during the terminal phase of a serious life-limiting illness. The scope of palliative care has expanded greatly and is now called end-of-life palliative care. Life-limiting illnesses, including cancer, heart failure, and COPD, dementia, and end-stage kidney disease, are now included. Palliative care's interdisciplinary team members, which include physicians, social workers, pharmacists, nurses, chaplains, physical therapists, occupational therapists, certified nursing assistants, and others. Communication among treatment team and patient and family is important for optimal care. Services are provided in varied settings, including home, long-term, and acute care facilities, and most recently integrated into the care in the emergency departments and ICU.
Respiratory failure results from inadequate oxygen or gas exchange.
The overall goals focus on maintaining and improving quality of life for all patients and their families, provided
an inadequate carbon
during
dioxide
any
removal
stage of a life-limiting illness, whether acute, chronic, or terminal. Palliative care aims to prevent and relieve suffering through effective pain and symptom management, and extends care into the period of end-of-life care as well as bereavement following the patient's death. If you look at Table 10.1, you'll see the goals for palliative care. Palliative care often includes hospice care before or at the end of life. Hospice is not a place, but a concept that helps people live as fully as possible during their last days of life. Palliative care is different. It allows a person to simultaneously receive curative and palliative treatments. Hospice care is initiated only after the decision not to pursue a cure. Hospice programs emphasize end-of-life care with focus on symptom management, advanced care planning, spiritual care, family support, palliative rather than curative care, and quality rather than quantity of life. Hospice programs may be hospital-based, part of a home health care agency, freestanding, or community-based. Interdisciplinary care is provided in homes and in home-like acute care and long-term care facilities. Hospice teams include physicians, pharmacists, dietitians, physical therapists, social workers, CNAs, members of the clergy, and volunteers. Services are available on an intermittent, on-call, part-time, regularly scheduled, or continuous basis up to 24 hours a day. Hospice nurses are pivotal in the coordination of the team. They are educated in pain control, symptom management, spiritual assessment, and management of family needs. Hospice nurses need excellent teaching skills, compassion, flexibility, cultural competence, and adaptability. About 42% of the patients who die in the United States are under the care of a hospice program. More than a third of the patients are over 85. 83% are over 65, of which 40% have a cancer diagnosis. Currently, the median length of stay in a hospice program is 21 days. However, the decision to begin hospice care can be difficult. Patients and healthcare providers may lack information about hospice care and services. Patients and families may see it as giving up since they cannot be receiving curative, life-prolonging treatments. Physicians may see it as a personal failure. 80% of patients using hospice services are white. Some cultural and ethnic groups may undergo hospice because of lack of awareness. Some cultural and ethnic groups may underutilize hospice because of lack of awareness of hospice services. The desire to continue with potentially curative therapies and concerns about lack of minority hospice workers. Patients must agree in writing that only hospice care and not curative care can be used to treat their terminal illness. Patients can withdraw from the program at any time, for example, if their condition unexpectedly improves. Patients can receive care for other health programs that begin after starting hospice. For Medicare and Medicaid and other insurances, 2 physicians must certify that the patient is terminally ill with less than 6 months to live. If the patient lives beyond the expected prognosis, they can be recertified, and reimbursement for care will continue if the patient still meets enrollment criteria. After initial certification, only 1 physician, that is, the hospice medical director, is needed to recertify the patient. Let's look at a question. The nurse explains to a patient with advanced cancer about the differences between hospice and palliative care. Which statement, if made by the patient, indicates that teaching was effective? Hospice care is not available if I'm in the hospital. Palliative care provides better methods of pain control. Hospice care will help me and my family prepare for death. Palliative care does not include any advanced directives. The correct answer is C. Hospice care provides compassion, concern, and support for the dying. The emphasis of care at the end of life is on symptom management, advanced care planning, spiritual care, and family support, including bereavement. Hospice care may be delivered in a variety of settings, including home, inpatient settings, and long-term care facilities. Let's do a case study. EM is a 69-year-old married female. Yesterday, the doctor told her there's nothing more they can do. When you walk in the room, she says, "I don't know what to do. I just want to go home. But my husband still works every day." List some reasons you'd need to talk openly with her. You should consider that you should talk openly with her to understand her concerns and wishes, to communicate and help diminish her anxiety, and she needs accurate information about and options about her care. Death occurs when all vital organs and body systems cease to function. Irreversible cessation of cardiovascular, respiratory, and brain function. Brain death is a clinical diagnosis that includes patients who have a heartbeat and are maintained on mechanical ventilation in the ICU. Technological developments in life support have led to questions about when death actually occurs: when the whole brain, cortex, and brainstem ceases activity, or when function of the cortex alone stops. In 1995, the Quality Standards Subcommittee of the American Academy of Neurology recommended diagnostic criteria that must be validated by a physician: coma or unresponsiveness, absence of brainstem reflexes, and apnea. Currently, legal and medical standards require that all brain function must cease for brain death to be pronounced and life support to be disconnected. In some states and under specific circumstances, registered nurses are legally permitted to pronounce death. Diagnosis of brain death is of particular importance when organ donation is an option. The Institute of Medicine defines the end of life as the period of time during which an individual copes with declining health from a terminal illness or from the frailties associated with advanced age, even if death is not clearly imminent. Uncertainty about how close at hand the end is adds to the challenge of answering patient and family questions, including how much time is left. Today, because of the graying of America and the increasing numbers of persons with chronic diseases, terminal illnesses, and dying have received greater attention. Nurses spend more time with patients near the end of their life than do any other healthcare professionals. The goals of end-of-life care are to provide comfort and supportive care during the dying process, to improve quality of the remaining period of life, to help ensure a dignified death and to provide emotional support to the family. Manifestations at the end of life include the fact that respirations may be rapid or slow, shallow and irregular. Breath sounds may become wet and noisy, both audibly and on auscultation. Death rattle is noisy, wet-sounding respirations due to mouth breathing and mucus in the airways. Breathing slows at the end to terminal gasps, described as guppy breathing. Shane Stokes is a pattern of respiration characterized by alternating periods of apnea and deep, rapid breathing. The sense of touch is decreased at first in the lower extremities because of circulatory alterations. In addition to these physical manifestations of the sensory system, eyes might look sunken and glazed. Mottling looks faintly like purple and white leopard skin. And the skin cools first on the lower and then the upper extremities and finally the torso, unless a fever is present. Kidney function and sphincter control diminish. Pain-relieving drugs can accelerate the loss of GI function. There's a gradual loss of the ability to move and trouble holding body posture and alignment. Jerking is seen in patients on large amounts of opioids. There may be an increased heart rate with later slowing and weakening of the pulse. The rhythm may be irregular, the blood pressure is decreased, and delayed absorption of IM or subcutaneous drugs occurs. A variety of feelings and emotions affect the dying patient and the family at the end of life. Most patients and families struggle with a terminal diagnosis and the realization that there is no cure. Patient and family may feel overwhelmed, fearful, powerless, and fatigued. Family responses dependent on the type and length of the illness and the relationship with the patient. The patient's needs and wishes must be maintained. The patients need time to think and express their feelings, and fatigue, weakness, and confusion might decrease their response time. So patience is a virtue. The time spent in bereavement depends on a number of factors, including how attached one was to the person who died and how much time was spent anticipating the loss. Although often used interchangeably, bereavement refers to the state of loss and grief refers to the reaction to loss. Grief occurs in response to real loss as well as what might have been. Psychologic responses include anger, guilt, anxiety, sadness, depression, and despair. Physiologic reactions include sleeping problems, changes in appetite, physical problems, and illness. Grief is a complex and intense emotional experience that affects all aspects of life. Primary interventions provide for patients to feel and express feelings. Many factors shape the manner in which a person grieves. The relationship with the patient who has died, the physical and emotional coping resources, concurrent life stresses, cultural beliefs, personality, mental and physical health, economic resources, religious influences and spiritual beliefs, family relationships and conflicts, social support, and time spent preparing for death. Not everyone experiences all the stages and not necessarily in progressive order, but Elizabeth Kubler-Ross defined the 5 stages of grief and grieving in the 60s. Denial may last minutes to months and be characterized by withdrawal. Anger may be focused in any number of directions: the person who inflicted the hurt, the world for letting it happen, at oneself even though nothing could have been done to stop an event from happening, like a car accident, bargaining for more time or something other than death. Depression may be expressed in numbness, anger, or sadness. Admitting the reality of the loss results in a calmer phase known as acceptance. Table 10.4 describes Kubler-Ross's model of grief. Another model of grief is the grief wheel. After a person experiences the loss, there is shock, numbness, denial, or the inability to think straight. Then comes the protest stage, where a person experiences anger, guilt, sadness, fear, and searching. Then comes the disorganization stage, where one feels despair, apathy, anxiety, and confusion. The next stage is reorganization, where the person gradually returns to normal functioning, but he or she feels different. Then the final stage is the new normal. Eventually, the destabilization experienced in grief will resolve, and the normal state can begin. Because of the loss, the normal state is not the same as before. The challenge is to accept the new normal. Trying to go back to the old normal, which is not there anymore, is what causes a great deal of stress. Anticipatory grief is suffered by the caregivers of patients with chronic illnesses, who often begin to grieve long before the actual death. Patients can also experience anticipatory grief toward the end of their lives. Adaptive grief is grief that helps accept the reality of death. Working in a positive way through the grief process helps to adapt to loss. It's a healthy process and may occur before death actually occurs or when death becomes inevitable. Dysfunctional grief is a prolonged grief disorder. Physical and psychological impact of a loved one's death may persist for years, formerly called complicated grief. It can include symptoms such as recurrent and severe distressing emotions, intrusive thoughts related to the loss of a loved one, self-neglect, denial of the loss for more than 6 months, feeling stuck and unable to move forward, increased risk for illness, work, and social impairments. The studies indicate grief disorder is less likely following deaths in hospice as opposed to acute care settings. Bereavement programs assist survivors to transition to life without the deceased person. The grieving process takes time, energy, and work. The process of resolution in normal grief may take months to years. Grief counseling facilitates discussion of feelings and cultivates an environment for open expression of all feelings, including anger, fear, and guilt. Respect for privacy and the desire to talk or not to talk is important. Honesty in answering questions and giving information is essential. EM's husband stops by before you enter the house to make your hospice visit to his wife. He says, "I can't do this anymore. All we do is fight. I can't believe this is happening." What are some possible reasons for the turmoil in this relationship? Well, it's a normal patient and family reaction to grieving. Possibly, it's dysfunctional grieving concerns beginning to surface. There's an overwhelming concern with decisions and care, and the caregiver is very stressed. Possibly it reflects the need for further symptom management, such as unresolved pain, and the need for further care or support. Spirituality is those beliefs, values, and practices that relate to the search for existential meaning and purpose. It may or may not include the belief in a higher power. It does not necessarily equate to religion, and various preferences should be noted. A person may be of no particular faith but have deep spirituality. Some patients may choose to pursue a spiritual path, some may not. Their individual choice needs to be respected. The patient and family's preferences related to spiritual guidance or pastoral care services should be assessed and appropriate referrals made. Questions to guide a spiritual assessment can be found in Table 10.5. At the end of life, many patients question their beliefs about a higher power, their own journey through life, religion, and an afterlife. Spirituality is associated with decreased despair at the end of life. However, spiritual distress may occur. Deep-seated spiritual beliefs may surface when patients deal with their terminal diagnosis and related issues. Some dying patients are secure in their faith about the future. They experience decreased despair at the end of life, may relinquish material possessions, focus on values they believe will lead them to another place. Religion may provide order to a world even in the presence of physical decline, social losses, suffering, and impending death. And it may offer existential meaning that provides peace and recognition of one's place in the broader cosmic context. Characteristics of spiritual distress include anger toward God or a higher being, a change in behavior and mood, desire for spiritual assistance, and displaced anger toward clergy. Culture affects decision-making with regard to life support and withholding and withdrawing of treatments. In some groups, death and dying are private matters shared only with significant others. Feelings are often repressed or internalized. Beliefs include toughing it out and being strong. Some groups, such as African Americans and Hispanic Latinos, easily express feelings and emotions. Kinships are very strong in Hispanic cultures. Both immediate and extended family provide support, and the expression of feelings is encouraged and accepted. Some groups are less likely to use palliative or hospice care in general. African Americans value toughness in times of hardship, rely on God, and use hospice care less often. Spouses and daughters need to be involved in Hispanic decisions. Families decide if terminal diagnosis, life support, and withholding treatment should be discussed with the patient in the Filipino-American cultures. Jewish Americans believe the spirit should not be alone when it leaves the body, so keep constant vigil and expect all body tissues to be buried with the individual. Puerto Rican Americans may want to kiss and touch the body after death to say goodbye. Perceptions such as giving up need to be clarified through open discussion about philosophy in hospice and palliative care. Cultural variations in the use of services and symptom expression, including pain, exist. Non-English speaking families are at risk for receiving less information about illness, prognosis, and care. Culturally competent care requires greater attention to nonverbal cues such as grimaces, body position, and decreased or guided movements. Individualized assessments of suffering. Early input from patient and family for care before death and care for the body after death. Culturally competent care also requires avoiding stereotypes, suggesting grief and bereavement counseling for the family, accommodating language, diet, and cultural beliefs and practices, and using medical interpreter services when indicated. Every visit you make to EM, her house is filled with visitors. You need to ask some questions, but she seems reluctant to let go of their hands. What should you do? Ask EM's husband what to do? Tell everyone to leave, she needs rest? Or explain to EM why you need privacy and then follow her wishes? C would be the most correct answer. Patients have the right to give and withdraw consent at any time when it comes to the issues of privacy and care. Her wishes should be respected and followed. Comfort and care take priority unless they are extenuating circumstances. Legal and ethical issues are something that many patients and families struggle with. It's important to provide information so that care outcomes are based on the family's wishes and values. For example, organ donation. This decision can be made by legally competent persons. can include any body part of the entire body, can be made before death, can be made by the immediate family following death. Family permission is still required at the time of donation. It can be specified on donor cards or in some states on driver's licenses. It can be handled by various agencies that differ by state and community, such as the organ bank or the organ sharing network. You must follow specific legal guidelines for tissue and organ donation. Some tissues must be used within hours after death, so require immediate physician notification. An advance directive is also called a living will by some. Most states now have natural death acts that may include directives to physicians, durable power of attorney for health care, medical power of attorney. Unique requirements vary by state, but allow an individual to tell the physician exactly what treatment is or is not desired. Copies of forms can be obtained from the internet and local medical associations, but are not required. Verbal directives can be given to physicians in the presence of two witnesses. Surrogate decision makers, most often family and the significant other, determine measures when the patient is not capable of communicating, and decisions should be documented. Table 10.6 describes common documents used in end-of-life care. Patients often change their mind as the disease progresses, so reassessment of advance directives is important. And you need to consider the patient's values and manner of life in order to make healthcare decisions for cognitively impaired older adults. CPR is given for respiratory and cardiac arrest unless otherwise ordered by a physician. However, whether and to what extent CPR is used is no longer the sole decision of the physician. The ANA supports patient rights to self-determination and the primary role of nurses in supporting patient and family decisions. Full code refers to use of complete and total heroic measures, including CPR, drugs, and mechanical ventilation. A chemical code involves use of drugs without CPR. DNR indicates comfort measures only without interference of technology. In some states, there's an out-of-hospital DNR for patients being cared for outside of acute care facilities. Terms are now being used to replace DNR. AND means allow natural death. More accurately conveys what actually happens. Also refers to comfort measures only. Comfort measures include pain control and symptom management, and natural progression to death is not delayed or interrupted. Euthanasia is a deliberate act of hastening death. The ANA statement on active euthanasia states that the nurse should not participate. According to the ANA, it's a direct violation of the Code for Nurses, the ethical traditions and goals of the profession, and its covenant with society. The ANA has taken a specific position stating that foregoing nutrition and hydration should be made by the patient or surrogate with the healthcare team. Nurses are responsible for becoming familiar with state, local, and agency procedures in end-of-life care and documentation. All caregivers responsible for the patient need to know the patient's wishes. Clear terms about withdrawing or withholding treatment must be included in the advance directives. Advance directive and organ donor information should be located in the medical record and clearly identified on the patient's record and/or the nursing plan of care. During one of your hospice visits, you notice that EM's recently lost weight. When inquiring about her intake, she says, "I don't want to eat. I just want this to be over." What should you do? Well, complete a more thorough assessment of the availability of foods that she may be interested in. Perhaps it's time for a family conference with the interdisciplinary team to discuss EM's rights and how to provide quality care. Review system function for indications of decline, especially GI status, urinary output, and skin condition. Nurses spend more time with patients near the end of life than any other health professional. Respect, dignity, and comfort are important to the patient and family. Nurses need to recognize their own needs when dealing with grief and dying. Understand that holistic nursing management focuses on psychosocial and physical needs. It looks at psychosocial manifestations, the grieving process, and physical changes associated with dying. Your assessment varies with the patient's condition and proximity of the approaching death. Limit it to the essential data. Use a health history information when possible, and document the specific reason for any patient's admission. Be sensitive. Don't impose repeated and unnecessary assessments. Use the medical record data rather than tiring the patient with interview questions. Specific events or changes that brought the patient in should be documented. The patient's medical diagnoses, medication profile, and allergies are recorded. If the patient's alert, briefly review the body systems to detect signs and symptoms, and assess for discomfort, pain, nausea, and dyspnea. Assess coping abilities of the patient and family. Promptly address any discomfort, evaluate and manage comorbid healthcare problems, gather information about the abilities, intake, rest, and general response to the terminal illness and its prognosis, and determine the family's ability to manage and cope with the needed care and consequences of the illness. The frequency of the assessments depends on stability, but it's done at least every 8 hours in the inpatient setting. As changes occur, the assessment and documentation need to be done more frequently. This seems sometimes like a burden to families, but physical assessments should be abbreviated and focus on changes that accompany the terminal illness. Assessment may occur weekly for patients cared for in their homes by hospice programs. In the final hours of life, physical assessment may be limited to essential data. Key elements of social assessment include family relationships, communication patterns, differences in expectations, interpersonal conflicts, and patient and family goals. As death approaches, monitor for system failure. Attention to subtle physical signs require vigilance. Multiple systems often fail during the end-of-life period. Neurologic assessment is especially important. Level of consciousness, presence of reflexes, and pupil responses. Evaluate changes in circulation, vital signs, skin color, and temperature. Monitor and describe the respiratory status, character and pattern of respirations, and the breathing sounds. Monitor intake and output, nutrition and fluid intake, urinary output, bowel function for renal and GI functioning, and ongoing condition of fragile skin that can easily break down. The nursing diagnosis is related to the psychosocial, spiritual, and physical concerns that accompany end-of-life care. Nursing management planning should focus on the coordination of care, the patient's needs, family and significant others' needs, and comprehensive plan to support, teach, and evaluate. A family conference may be helpful. The nursing goals are comfort measures, emotional and physical needs, and determining where the patient would like to die and if this is possible. ICU is where many patients experiencing brain death spend their last hours. Planning for end-of-life care may be particularly challenging here. Organ donation may be brought up, and consultation from palliative care specialists may help with coping. Psychosocial and physical care are interrelated. Ongoing information on disease, dying process, and care, coping strategies, and the denial of grieving may be barriers to learning. Teach the patient and family on how to cope with the many issues during this period of time. EM seems to be getting weaker. She offers little information and sometimes doesn't even open her eyes when you are there. She used to look forward to your visits. How will you know she is close to the end of her life? What are some of the physical and psychosocial signs you may notice? Well, you would notice cardiovascular signs, respiratory changes, GI and urinary changes, changes in skin color and condition, and the fact that the patient is more withdrawn and sleeping more. Anxiety and depression may be caused by uncontrolled pain and dyspnea, psychosocial factors from the disease process or impending death, altered physiologic states, drugs used in increasing doses, etc. The management would be encouragement, support, and education. Table 10.9 has information on the management of psychosocial manifestations near death. Anxiety is an uneasy feeling whose cause is not easily identified. Frequently, it's related to fear. Manage these things with medications and non-pharmacologic interventions, relaxation breathing, muscle relaxation, music, and imagery, to name a few. Anger is often felt by surviving family members. You may sometimes be the target of this anger and must understand what's happening and not react on a personal level. It's a common and normal response to grief. The grieving person cannot be forced to accept the loss. Encourage expression of feelings, at the same time realizing how difficult it is to come to terms with such a loss. Hopelessness and powerlessness are common emotions at the end of life. Encourage realistic hope within the limits of the situation and help with decision-making about care that can foster a sense of control and autonomy. So allow the patient and family to deal with what is within their control and help them to recognize what is beyond their control. There are 4 specific fears at the end of life: pain, shortness of breath, loneliness and abandonment, and meaninglessness. You need to help the family by encouraging coping strategies. Many people assume that pain accompanies death. Physiologically, there is no indication that death is always painful, and psychologically, pain may occur based on anxieties or separations related to dying. Terminally ill patients experiencing pain should have pain-relieving drugs available. Most patients want their pain relieved without the side effects of grogginess or sleepiness. Pain relief measures do not need to deprive the ability to interact with others. It's important not to delay or deny relief measures to a terminally ill patient. Assure patient and family that drugs will be given promptly when needed, and the side effects of the drugs can and will be measured. Patients can participate by discussing pain relief measures and their effects. Fear of dyspnea can be a problem. Sensation of air hunger results in anxiety for the patient and the family. The current therapies involve the use of opioids, bronchodilators, and oxygen, depending on the cause of the dyspnea. Respiratory distress and dyspnea are common near the end of life. Anxiolytics may help produce relaxation. Many patients are afraid of loneliness and abandonment. They don't want to be alone. They worry that loved ones can't cope and will abandon them. The presence of the loved one or caregiver provides comfort, security, and support. Holding hands, touching, and listening are important nursing interventions. The fear of meaninglessness often leads people to review and examine their lives. It helps recognize their lives' value. Its worth needs to be expressed and enhances spirituality and provides comfort. Patients need to review their intentions, examine their actions, express regrets about what might have been, respect and accept practices and rituals associated with life review, and remain non-judgmental. And there are practical ways of helping, which may include looking at photo albums and collections of important mementos. Communication among healthcare providers and the patient and family is essential at the end of life. Use empathy and active listening, and allow patients and families time to express their feelings and thoughts. Empathy is identification with and understanding of another's situation, feeling, and/or motives. Active listening is paying attention to what's said, observing nonverbal cues, and not interrupting. Families and patients may have difficulty expressing themselves emotionally. Make time to listen and interact in a sensitive way to enhance the relationship among you, the patient, and family. A family conference can create a more conducive environment for communication. Other end-of-life considerations with communication include silence and confused, disoriented, or garbled communication. Frequently, silence is related to the overwhelming feelings experienced at the end of life. Listening is essential and sends a message of acceptance and comfort. Silence can also allow time to gather thoughts. Communication needs to consider the patient's ethnic, cultural, and religious backgrounds. The patient near death may seem to be withdrawn from the physical environment, maintaining the ability to hear while not able to respond. Unusual communication may take place. Patients may speak to or about family or others who have predeceased them, give instructions to those who will survive them, and speak of projects yet to be completed. Careful listening is important. It helps identify specific communication patterns and decreases the need for inappropriate labeling of behaviors. Physical care focuses on the needs for oxygen, nutrition, pain relief, mobility, elimination, and skin care. Skin integrity is difficult to maintain at the end of life because of immobility, urinary and bowel incontinence, dry skin, nutritional deficits, anemia, friction, and shearing forces. You're on call for the hospice team when your pager sounds at 3 a.m. It's EM husband, and he tells you that his wife can't catch her breath and is very anxious. What might be happening? Well, she might be experiencing air hunger, and she may need oxygen. She may have unexplained anxieties and not be able to communicate her fears and concerns clearly. She may need to be hospitalized, and she may be approaching death. After the patient is pronounced dead, the nurse prepares or delegates preparation of the body for immediate viewing by the family. Close the patient's eyes and replace their dentures, and wash and position the body. Consideration must be given for cultural customs, state law, and agency policy and procedure. It may be important to allow family to prepare or assist in preparing the body in some cultures and some types of death. Remove tubes and dressings if it's appropriate, and straighten the body, leaving the pillow to support the head and prevent pooling of blood and discoloration of the face. In the case of an unexpected or unanticipated death, preparation of the body for viewing and release to the funeral home depends on state law and agency policies and procedures. Be sure you know what they are, because you might need to sequester equipment and things like that. The role of the family caregiver includes working and communicating with the patient and other family members and friends, supporting patient concerns and helping patients resolve any unfinished business. Family caregivers are important in meeting patients' physical and psychological needs. Often they face high levels of stress and emotional, physical, and economic consequences for caring for a dying member. Responsibilities do not end when the person is admitted to an acute care facility. An understanding of the grieving process for patient and family caregivers is important. Caregivers at higher risk of dysfunctional grieving have concurrent life crises, such as divorce. Abnormal grief reactions may include dependency, negative feelings about the dying person, inability to express feelings, sleep disturbances, history of depression, difficult reactions to previous losses, perceived lack of social or family support, low self-esteem, previous bereavements, alcoholism, and substance abuse. Encourage caregivers to facilitate the building of a support system of extended family, friends, and the faith community and clergy. A bond or connection may develop between you and the patient and/or the family. Be aware of how grief personally affects you. When dealing with death and dying, you're not immune to feelings of loss, helplessness, and powerlessness. Express feelings of sorrow, guilt, and frustration. Be aware of what you can and cannot control. Realize it's okay to cry with the patient or family. Focus on interventions to decrease your own physical and emotional stress. Get involved in hobbies and other interests. Schedule time for yourself. Maintain a peer support system and develop a support system beyond the workplace. Hospice agencies can provide care for their team with professionally assisted groups, informal discussion sessions, and flexible time schedules. EM dies and you attend her funeral. Since that time, you're unable to sleep and have recurrent thoughts about what you should have done for her. You are unusually tired and have no appetite. What's happening to you and what should you do? Well, you may be experiencing normal grief. You may be experiencing caregiver stress. Perhaps you could discuss your feelings with the hospice chaplain. Resume your exercise program. Call an old friend and go to lunch. Attend a bereavement program. Take up tennis or take an art class, etc. Let's do one last question. The hospice nurse visits the wife of a dying patient. The nurse is most concerned if the patient's wife makes which statement? I don't think I can live without my husband to take care of me. I wonder if expressing my sadness makes my husband feel worse. We have shared so much that it's hard to realize that I will be alone. I don't feel guilty about leaving him to go to lunch with my friends. The correct answer would be A. Normal reactions to loss include statements in options B, C, and D. Option A indicates an abnormal grief reaction and possible suicidal thinking.